So thank you all for coming today to hear our team presentation from Lowell General. Since it is noon, I'm going to go ahead and get us started with our usual housekeeping and Penguin announcements while people trickle in. So welcome. For attendance purposes, please put your name and institution into the chat as always. And optional, we would love to hear any QI successes, big or small, that your hospital team may have had over the last month since we last met. As usual, please mute yourselves when not speaking, and feel free to type your questions into the chat during the webinar. We will have time for Q&A and discussion after the presentation. And the session's being recorded, and we'll upload it with the slides to our website afterwards for anyone who isn't able to make it. So I'll jump right into announcements so we can get to the good stuff. As always, we thank our Penguin Equity Bundle Work Group for everything that they have contributed over the last year and a half to this important work in our state. And we thank all of you, the hospital teams, for joining us month to month on these webinars and for continuing to submit your monthly data so that we can continue to work together and progress on this bundle. So a few announcements. We hope you all had a happy National Nurses Week. For those who may not know, each year in May, nationally, we recognize nurses for their service and dedication to caring for others and improving the health of patients across the country. And we also just wanted to say a special thank you to the nurses here who are affiliated with Penguin. We would not be where we are today without our nursing leaders and colleagues. So thank you. Upcoming presentations. This is our second to last Equity Bundle webinar. So sad, but we are so excited to welcome Lowell General today. And then we are not having a monthly webinar next month in June due to the Penguin Summit, but then we'll be back once more in July on the 16th to hear from Tufts. So the Equity Bundle, this current version is ending at the Penguin Spring Summit on June 26th. We're having a maternal-focused breakout session in the afternoon of the summit where Dr. Meadows will be presenting sort of an Equity Bundle wrap-up, our progress to date. And then immediately following that presentation, we will be having a kickoff for our next bundle for perinatal mental health conditions. So we hope you all are able to join us for those presentations. This week, there is a webinar from the Health Policy Commission and the Massachusetts Department of Public Health featuring an important project called Inviting Narratives of SUD Treatment in the Perinatal Period, a focus on race and equity. The acronym for that project is INSPIRE. You may have heard of it. Penguin has supported this project since its inception, and the webinar will highlight the main findings from the project. And so it'll be a really exciting event, and we hope you all can make it. Caroline will be putting the registration links for upcoming events and resources in the chat for you. Some of you joined us last Friday for the most recent Speak Up Ambassadors training. So if you are a Speak Up Ambassador, you are eligible to apply and become Speak Up faculty. Which allows you, this is the sort of train the trainer section of the Speak Up Action Pathway, and the faculty training prepares you to deliver Speak Up trainings at your own institution. So the application deadline to become faculty has changed. It was June 1st, it is now July 1st. So you have a little bit more time to apply, which is great. Speaking of Speak Up, there is a National Speak Up Champion course happening on June 14th and 21st, and we are able to send 20 people from Massachusetts to this course for free. So if you've not yet taken Speak Up or know of somebody who would still like to, please register using this promo code to sign up for that training for free and join us at Speak Up. Again, just a plug for the Penguin Summit. This is happening June 26th from 8:30 to 4:30 in Norwood at the Four Points Sheraton Hotel. We're really excited for this year's Spring Summit. Our theme for for this spring is Partners in Purpose. Collaboration is key to family health and equity. So also from our friends at PQI, they recently developed a birth equity modules course, which includes 4 around 30-minute web-based modules designed for healthcare professionals working to ensure health equity. So there are 4 modules, and these modules were based on the PinQuin PQI Equity webinar series that occurred in early 2022. So each webinar has been transferred into a module format. This version of the course, there are not continuing education credits yet, but I know that PQI is applying for them to be accredited. So you can keep an eye out for credits to come very soon. And the best part of all is, due to our long working relationship with PQI, they have given free access to these modules for Massachusetts perinatal providers until September 30th. So there's a code here on the slide, and Caroline's putting it in the chat, so be sure to take advantage. And as always, we have the beautiful PinQuin website stock full of amazing resources that we didn't cover today, so be sure to check out our library. And now I'll turn it over to Dr. Meadows to set the stage for our team presentation. Thanks, everyone.
Thanks, Kaylee. Excuse me. I'm really excited to show continued data of what teams are accomplishing in Massachusetts. And first, I want to echo Kaylee's comments and sentiments. I want to thank everybody for all of the work you do every day. All of us are doing equity work every day in our lives, and in the way we deliver care. It's just capturing our ability to say that we are doing that. And in our formal team designs across different hospitals across Massachusetts, we're now usually at around 100% of those who are reporting that they have an equity team. As you see, February only had 6 respondents, but in January we had 12, and we had an increase in the number of those that first said they did not have equity teams, and then more having equity teams. So it's great to hear from Sarah to talk about the work they're going to do or what they've been doing in their equity team. If you go to the next slide. Things we want to make sure that we want to underscore that are really important and core to quality improvement, and that is that when we have an equity team, we want to make sure that in order to do the work that's necessary to think about the populations that we're serving, that it's great to have a diversity of roles from physicians, nurses, social workers, quality leads, et cetera, even students and staff that work within your L&D. And so we're moving what we want to see on these slides. And so I'll say this often to you guys, we want to see all blue. That would mean that we've all met those goals. And so what we don't see is as much dark orange. So you can see as we move to the right, we're improving because we're seeing less dark orange and a little bit more blue of those who've reported. And so we're seeing more increased diversity of roles within our equity teams. We'll go to the next slide. We also see that as folks in their equity teams are stating their goals and really espousing what their values are for their department, people are creating anti-racism statements. In our department here at UCS San Diego, we call ours a value statement now. That term seemed to resonate better with our department. Others I've seen have a really nice name of calling it an equity statement. And so some folks have moved in that direction. We've had a number of departments increase over time that have created those. Some of those come and they go, I will admit. I've seen some hospital systems have them and then some take them down. But even whether that's internally facing or externally facing, it's great for everybody to be able to feel like we know what we stand on and what the values are for the department, for the work we're moving forward to do. So you go to the next slide. Another thing that we'd love to see a sea of all blue is that in making sure that we have our aim statement, our goals, our SMART goals for the work we're trying to do. You can see from February 2023 to February 2024, we have increased. Now we still see a lot more orange than what we want to see in those last 4 to 5 months. And so the goal is to continue to, once you form your equity team, it's diverse in its roles, that you continue to really set goals and communicate those goals to your equity teams and to your L&D department and all the members that serve L&D and outpatient obstetrics, so that everyone is aware of what we're working toward to ensure that we're giving the best care and the most inclusive, excellent care that we can to all of our patients coming in. All right, so we'll go to the next slide. I think that wraps up maybe. Oh, no. So in addition, we actually are still seeing that folks are doing a great job collecting data. by race, ethnicity, and language. You can see toward the right of both of those sets. So race at the top, ethnicity in the middle at the top, and language on the right at the top. You see where we've gotten more blue toward the right of each of those sets. And if you go to the next slide, we're still working on demographic data collection for those who are differently abled, for gender identity and sexual orientation, but that has improved some as well. But it's been more static compared to the other for race, ethnicity, and language. All right, we'll go to one more slide. Data stratification. So this is where we've actually wanted to really lean in and ensure that teams recognize that one of our greatest goals is that everyone who has an equity team, their equity team can lean in, and a member of their equity team can be a part of every initiative that your L&D or outpatient obstetrics teams are working on, to make sure that we're looking at not just the population, everybody being served, but all populations. And you know who those populations are for your own institutions, whether that be folks who speak a different language or folks that are coming from geographic distances, or whether that's race, ethnicity, or sexual orientation or gender identity, or maybe even Medicaid versus non-Medicaid. You know who your populations are. They vary depending on your hospital. But with that being said, making sure that you're looking at the differences that of the folks that you serve, and ensuring that when you're running reports to look at percent breastfeeding leaving the hospital or percent NTSV and those kinds of things, you're looking at it by language or by race or by other demographic identifiers to ensure that everyone is getting the care they need. All right, we'll go to the next slide. And for training, so this is the slide that shows the proportion of training within the last 2 years for implicit bias, racism, and racial disparities. And we've brought that training to Massachusetts. Many other different training options can be used, but Speak Up has been a really great option for everyone. We had done really well up until the end of 2023, and now we see in the beginning of 2024 less reported percentages of those who have been trained in the last 2 years, mostly because of the fact that a lot of our training started in 2020. And we know that people hadn't renewed their training. So when you go to the next slide, we also look at this for some of the smaller hospitals, those that do less than 1,500 deliveries. And we see also lower numbers. So numbers have gone down, when prior to that, those who served those hospitals that had less deliveries actually had greater rates of training. When you go one more slide, we'll look at the hospitals that deliver babies over 1,500 deliveries a year. You go to the next slide. There it is. And what we're seeing is greater rates of those being percentage being reported. So I'm not sure. I want to put out there to folks to say, you know, if you're reporting this data, maybe we can make sure that your data is correct versus that the data is reflective of who is serving your L&D or your outpatient spaces. Could also be due to travelers or folks that haven't had the opportunity to train, or new hires. But it's really important to know that we have Speak Up still available. We will plan to continue to have Speak Up available so that we can continue to do those trainings. But I just want to sort of give a hand clap to that February of 2024 to see 100% of physicians and nurses trained in bias. All right, we'll go to the next slide. And I think we're getting, without further ado, we're going to bring to the microphone Sarah Thibodeau and Libby, is it Cino? Libby, am I saying it right? To talk about what they're doing at Lowell General Hospital under Tufts Medicine. So I'll pause and turn it over to you guys. Thanks.
Great. Thank you so much, Audra. So my name is Sarah Thibodeau. I am the OB nurse educator for our labor and delivery and mother-infant units here at Tufts Medicine Lowell General. And I've been in this role for about 7 years. I do education really for the mom side of things, less so the newborn side of things. And I've been very involved in getting our maternal child health equity working group up and running. If you could go to the next slide. So we started this work, like many of us, in 2020. Tufts Medicine as an organization created and opened the Center for Diversity, Equity, and Inclusion. And then in September of 22, as part of this group, we undertook implementation of the AIM Equity Bundle. That was initially, it was our labor and delivery and mother-infant units that were involved in that. And so the following month, we formed what we were calling the OB Equity Working Group at that time. And we are so fortunate to have very good support from our Director of Maternal Child Health, Laura Federico, as well as our other senior nursing leadership and our managers. And so I ended up chairing that equity working group. If you could go to the next slide, please. Awesome. And so how did we start? At first, we met every 2 weeks because we were like, we got to get a handle on this. We don't exactly know what we're supposed to be doing. And we were trying to find a time that worked. We were meeting online, but we struggled to really find a time that worked that would allow us to have a diversity of roles and people. Initially, our first couple meetings, it was a handful of white nurses. That's what we had. So it was myself and one other nurse who sat down to start the process of an anti-racism statement. Initially, so that's 2 white staff nurses. We kind of went, okay, we're going to take a shot at this and do our best. So what did we do first? We basically Googled other hospital statements to say, what do they look like? And that was really enlightening, and there was quite a diversity. From there, we took our first pass at our draft. We sent it over to the Tufts Medicine CDEI. There's the head of that, Rodrigo, is very helpful. And then he actually came to our meeting and gave us some feedback and suggestions on our statement, specifically including adding some action items so that it was less theory and more practice. And then we also sent the statement along to risk management for review. And we already talked about speak up training once, but we really tried to get our staff to attend speak up training more and more. Yeah, and people loved it. Next slide. Here is our first attempt at creating a birth equity goal. We decided that by June 30th of 2023, we were going to disaggregate by race, ethnicity, and language spoken all the data that nursing reports out to everyone else on, including that from the birth log, the NTSB C-section rate, episiotomies, maternal transfers, and newborn transfers based on maternal data, as well as breastfeeding exclusivity. We also discussed applying an equity lens to the data that we are in fact collecting. This proved really challenging. I am going to say here that the past year has been a challenge overall for our hospital, and I think many other hospitals. But we had very difficult, first we were just like, okay, how do we do this? Who does it? And it turns out there were a lot more people involved than we kind of realized, right? So we had to kind of get coordinated, reach out individually and discuss things. We also, we went live with an Epic rollout, an EMR change 2 years ago. And initially we had to learn how to do our data collection now with this new EMR and what our tools were. And truthfully, how to navigate our EMRs, the way that we used to know how, we used to know it like the back of our hand. And we had to figure out, like, how do we find this information? Can we build a report? Is it going to show what's real? And then we had to dig in and figure out how we are actually collecting this data. And initially, when we started this work, we weren't sure, who exactly was asking these questions. They're supposed to be self-reported, but we really dug in to say, like, okay, so who is putting this in? Are we asking these at the OB offices? And should we be asking this again every time patients come in, or confirming this? And we have challenges with that too, because sometimes we have patients who are here twice a week for testing. So when is the appropriate time to do that? And is it every single visit? These were all questions. But as Tufts Medicine started to roll out some of the tools that Epic has for for collecting this data, it did absolutely get easy. We also determined that we wanted to share our the data that we were collecting as part of this bundle, our equity data, with the department every so often. And I think actually I will just show, I'll take this moment to share my screen, if that's okay. Okay. For just a moment. Thank you. There it is. So here is some of our data. I believe you all can see my screen. Great. This is our 2023 data. So you can see this is for the whole year. So our non-Hispanic Black patients with hypertensive crisis, you can see we've got our numbers treated within 60 minutes and our numbers not treated, right? So 25, 75. Our non-Hispanic white patients with hypertensive crisis, and it's a small, I should say, because totals aren't very large, right? We only had 8 Black patients who fell into this category. We had 27 for the non-Hispanic white patients. And they're very close. They're very close in the numbers. In terms of quantitative blood loss, we can see a little bit more of a disparity here. But the truth is that we need to kind of do better overall with this. And I'll show you the first 4 months of this year, that same data. So we actually have improved just with this preliminary data in the Black population. And it's a little bit of improvement in our non-Hispanic white population. We have some particular challenges around the QBL process. I will share, I'm sure we're not the only ones. We sometimes do have providers who are not interested in participating in that, is how I will say it. And I'll stop sharing now. Thank you, Kaylee. You can go back to the slideshow. So what we were hoping to do with this data is, and what we are doing, is we're thinking about what does the data show us and how can we follow the data and figure out what we need to check. One of the earliest metrics we talked about was looking at this data with our C-sections and our TOLACs specifically to see if there's disparity in what's being kind of, what's actually happening and who's having a TOLAC successfully. We haven't actually gotten to do that yet for various reasons, but that is on the docket. I will, yeah, and we're, and we have to see kind of what is revealed. Next slide, please. So how did we do with our first equity goal? I will say that it was difficult for us to measure in an exact way. It's a little bit difficult, but it absolutely, we definitely got much better about it. The only thing we are not great about is language spoken, which is interesting because we have a lot of folks who don't have English as their primary language, but we're not great about reporting that data. That's a goal. When I will say though, that because it was kind of a disjointed process and we had one person collecting this piece of data and the other person reporting on that, we made the inquiries formally to these individuals, but they didn't all do it right away because it's not an easy thing to necessarily do, depending on, what the situation is. But what really worked and started to change our culture was one of our OB providers, who is a member of our equity group. He really took the lead, and every time data was presented, he would say, "Can we see this data broken down by race, ethnicity, and language?" And that empowered others of us to do the same. I started to say, "Oh, that's a great, I'm going to ask this at the next meeting." And I do think that made an impact. I think that, we all have received the training, but taking the time, making it a priority, et cetera, absolutely needs to happen in a different way, right? Please go to the next slide. All right, and so then about a year ago, we kind of realized that we are such an interconnected maternal child health department. We share our patients who end up boarding with their newborns, go to pediatrics. It's all the same. And so we realized we were already kind of functioning as a whole maternal child health equity working group. So we formalized it at that time. This definitely diversified our group and included, we have a child life specialist, we have a neonatologist, we have OBs, we have nurses. We don't have a patient representative at this point. We have discussed how to do this, but it has had to, we haven't actually gotten there yet. We've been thinking about this, and that is a goal. And then to get back to our anti-racism statement, we started to distribute it. Next slide, please. We definitely received some feedback this time. This is part of the draft. I will say that this highlighted sentence was called out. It was, I'm going to read it to you. Black mothers are 3 times and Black infants 2 times more likely to die than their white counterparts. In their honor, we pledge to hear and amplify the voices of those who have been silenced and to challenge the institutions and interactions that create racism and violence, acknowledging that we in medicine have been part of the problem. So we had a pushback on a couple of levels. First, we had some folks who said, why are we going to say that people are more likely to die and hang it on the wall? That's going to scare everybody. And we had some great feedback working with our CDEI that this is not actually true, or that's not the motivating factor. But that the truth is that these moms that are coming in, they're well aware of the risks, and frequently they already have some level of kind of trauma sometimes from being a patient in the past. And we spoke to several people who said it's not scary. It's actually nice to know that they know that, and that's reassuring. And then the other piece that we got was the second line about acknowledging that we have been part of the problem. We had one particular provider who was pretty vocal about this and feeling like it was kind of opening up to risk. Next slide, please. And we didn't do anything with that information right away, to tell you the truth. We kind of brought it back for discussion. We went back to the larger Tufts Medicine CDEI. We brought it back to risk management, and then we kind of waited, and we just said, okay, let's keep going. We'll work on something else. These were the ideas we had for last year. Are there options beyond male and female on the birth certificate? What resources do we have for our LGBTQIA patients? And education topics. What is available? So we decided to focus on the education topics and make that our focus, because Tufts Medicine is very diverse, and in Lowell we have a bunch of key populations that often have different cultural understandings and desires, and it's really important that we give the right education in the language that they can understand. So what we did first, next slide please, was to create an inventory of what we have, like what is available in our system, what languages do we need? So our top 3 languages for sure, Spanish, Portuguese, and Khmer or Cambodian. And then the next top, there's also several more that reach that above 1,000 mark, right? Gujarati, Vietnamese, Haitian Creole, and Arabic. We do an incredible amount of interpreting via interpreter encounters every year. We also started to price out, like, how much does it cost to add to this? And we were surprised at how very much it did cost. Next slide, please. So this right here is a work in progress. This is all of the stuff that is, I'm sorry, it's a little bit cut off, but these are all the topics that we could find available in our system and the languages they were available in. You can see that we had nothing even available in Khmer, Cambodian, Gujarati, or Arabic, which are all kind of our, within that top, I guess it's top 7, not 6 languages. Next slide, please. We've also done things like, there's the Cambodian Mutual Assistance Association in Lowell, and we've reached out to them to say, can you assist with translation services? Because it is listed on their website, but we haven't actually heard back just yet. So we're working on that. Okay, and this slide, this is just to take a minute and talk about our challenges, right? So I've already mentioned some of these, like our, learning our new EMR, but we all know we've been very challenged with staff turnover, staffing the units. I'm an educator, so my primary role is to help get us onboarded with the right people, et cetera. Leaves of absence, which are just part of the deal. I myself had a leave of absence this past fall, and that definitely delayed things a little bit. We also lost positions supporting data collection. We used to have, initially, we had a grant-funded position with the Moms Do Care program, but those things run out. And when folks leave, sometimes the positions don't get replaced. So we've had to kind of spread the work around, which I don't think is unique to us. I think like the whole state and the whole world has been feeling strapped in terms of resources. And we decided to, and we've acknowledged that changing the culture is pretty slow. And are the concerns that were expressed about our anti-racism statement legit? Are they fear-based, or kind of a mix of both things? So we like I said, we brought it all back to our risk management, et cetera, and to our group. And we took a significant few months to think about it. And we ended up changing just one word. You could go to the next slide. If you read the second paragraph, we changed one word. I'll just let you all read it for a second, and I'm not going to read the whole thing out loud. It's very long. All right. I will read and point out the change, okay? We still said Black mothers are 3 times and Black infants 2 times more likely to die than their white counterparts during pregnancy or childbirth. In their honor, we pledge to hear and amplify the voices of those who have been silenced and to challenge the institutions and interactions that create racism and violence, acknowledging that we in medicine have historically been part of the problem. We added historically, and we decided that was our solution. We did not want to, we toyed with the idea of kind of softening this or making it more neutral. And we, after some discussion, agreed that would kind of go counter to what we were trying to do here. We wanted to keep it strong. But we also decided that what we were going to do is kind of slow down the process of getting us to accept this statement as a department. If you could go to the next slide, please. And what we did was we ended up as an equity group creating this short PowerPoint presentation and then started to circulate it around to various department meetings with whoever. A lot of us are already on different department meetings, and some of us got invited, like I went to the family medicine meeting. Next slide, please. And this is just one of the slides from that. We really wanted to, we kind of backed up a little. Instead of just saying, hey, we created an anti-racism statement, here it is. We said, oh, we are doing this as part of this reason. Here is why, because of this, maternal mortality. And this is why we're doing it, to increase equity, not just, we're not focusing on equality. And we've started to do this, and I will say the feedback has been different this time. I think that this is a helpful approach. Next slide, please. Okay, and then this past winter, we created ourselves a new SMARTY goal. And what we decided to do was to look at the breastfeeding exclusivity rate of our Asian identified population during their hospital stay, because we know that we have some information about this already. Luckily, our lactation consultants are great partners in this. And so they broke down the last 6 months for us. I don't know what happened in March, but we did a 76% exclusive rate, which is great. So this is kind of where we're starting. And what we want to do is improve the percentage of breastfeeding exclusivity in our Asian identified population by 10% within 6 months. And the current mean for the past 6 months is 46%, or average. Sorry, I'm going to close up. So that's kind of our starting place. And next slide, please. And we have actually looked at this before. This was a project that a couple of our lactation consultants did in the past. This has been kind of a challenge for us for quite a while. And so they had done a focus group and some themes. We have asked them to share that information, and we're thinking about ways we can be creative with this. We're going to focus on this for our National Breastfeeding Awareness Week coming up in August, and yeah, and we're excited about this. Next slide, please. And then now the other piece that we've been focusing on in the past year plus is trauma-informed training. We had the Moms Do Care grant several years back, and we had everyone trained in person, which was amazing. But we've had a lot of new staff since then, and we needed a refresher. We learned that we needed a refresher. So our fabulous clinical leader on labor and delivery, Libby Cino, did a bunch of research and created a PowerPoint presentation and a class, and has been teaching that in person. We also have, we have lots of SUD and mental health problems that co-occur with all of this, right? And yeah, and so now Libby is in the process of offering that trauma-informed training to all of maternal child health staff. And we wanted to give you a sample of that. So I will turn it over to Libby.
Thanks, Sarah. So can everybody hear me okay? Awesome. So we're just kind of doing a brief overview about how I go about teaching the class. Just giving a general guideline of what trauma is, and trying to lay the foundation that many people experience trauma without being traumatized, but the traumatic experience itself is almost always reflective of a loss of control or autonomy, which is very acute and very pertinent to labor and delivery, as you can imagine, because it's a very intimate time in a laboring person's life. Next slide, please. We start understanding the foundation that it's subjective. It's heavily influenced, and we talk about age and different developmental stages that impact that type of trauma, the type of trauma that we have, whether it's single, reoccurring, multiple events, and there's multiple different types of trauma that we elaborate and go further on during the class that takes a few hours. Talking about response of loved ones and availability of support, basically kind of laying the foundation that if you start off rocky on a foundation, your foundation is always going to be kind of rocky. Resilient and strong relationship acts as buffers on on people, but it doesn't prevent trauma. Next slide, please. So when you experience trauma, you have a brain change in your brain, an alteration that's actually reflective of a stress injury or a brain injury. So in general order of development, your brain develops from back to front. The back brain, the hind brain, right over back there, it's alive, it sustains life. Your autonomic nervous system responses, fight or flight, I'm alive. Your midbrain, or your forebrain, your midbrain, that's more for processing and emoting. So that is assigning appropriate emotions to and responses to threats. This is, I'm alive and I can understand, I can sense things. The forebrain is the response. That's the reasoning and the response, and the last to develop. And so this can calm that emotional reaction that you have when you're experiencing something that could be potentially traumatic. Next slide, please. I love to talk about the window of tolerance. I feel like I bring it up until like everyone is sick of hearing about it from me, because it's such a great visual of how everyone has an ability to tolerate so much stress before they don't. So most of us like to remain in the middle, right along there, and it goes up and it goes down based on our hormones, what's happened for the day, and X, Y, and Z. But it also impacts if you have a lot of trauma or if you have some significant trauma, because that can close that window and make that ability to stay within that window much, much more difficult, because they have a hard time regulating their emotions. Next slide. Thank you. I bring this up because according to SAMHSA, over 80% of IV drug users support multiple abusive or traumatic childhood events. About 90% of adults seeking substance use disorder treatment report at least 2 adverse childhood events, and people with 3 or more about 12 times more likely to complete suicide. I bring this up because it's not just an isolated event. This doesn't happen in a vacuum. I bring this up because setting the foundation to understand substance use and coping is part of trauma-informed care, part of causing the whys. Why? What caused this? Why? I wonder what happened. Bringing those, and we'll talk about that in a minute, into the nurse's forefront, into the provider's forefront. Next slide, please. And we talk about statistics and all this jazz, but we have, actually go through in the actual class itself, where we pull out adverse childhood experiences, which is the ACE study that we reference. If you haven't heard about it, you Google it. It's pretty much freely available, but it's a test of several different external and internal concerns for trauma, especially childhood trauma. And we found the more childhood trauma or ACE experiences, the higher the rate of the individual growing up with trauma or carrying trauma. 60% of sexual assault survivors are never going to report their assault. And if it's 90% on college campuses when it's handled internally, that means 90% of women, female presenting, these women, for the majority of these people, are being assaulted and then they're not being heard. So it's a 2-step process. It's almost like being assaulted or traumatized all over again when you're not being heard. It's the most underreported crime, and only with about 12% of child sex abuse being reported overall. The statistics are very sobering. 1 in 4 to 6 girls and 1 in 6 to 10 boys will be abused before they turn 18. The average age that a child becomes a victim to prostitution is between 11 and 14 years old. I bring all of these things up because if someone's never experienced these kind of statistics I'm talking about, or been personally impacted by some of these things, they're not always even aware of a person's reflection, reaction, reactivity, because they can't even get in their mind that these things may have happened to them, not just once, but multiple times. Next slide, please. So we talk about the window, using the window of tolerance as a metaphor. And I like to kind of, if I'm having a lot of anxiety, if I'm feeling like my fingers are numb, I know when I'm having anxiety, I think back to my window. Okay, where am I in my window? Am I hyper-aroused, or am I kind of freezing, fawning, doing all that stuff? And a lot of times it's just bringing awareness to your body and awareness to your muscles, the awareness of that you might be going out of your window. Next slide, please. And substance use has its role in coping and staying within that window of tolerance. It's self-soothing and it regulates your emotions, even if it is by blocking them out. It's escape. It communicates pain, and it can be viewed as self-harm in many ways. 9.2 million people aged 12 or older misused opioids in the past year. 46.3 million, people met the DSM criteria for having a substance use disorder. And out of that population of 46.3 million, only 94% of that population received no treatment. So only 6% of that millions and millions of people ever sought treatment. So we have people who are very limited capacity to be able to tolerate, very limited capacity to tolerate, big emotions and big experiences. Substance use makes sense because it's blunting and it's numbing those things so that they're able to tolerate. Next slide, please. The benefit of using trauma-informed care and instituting it is because we know pregnant individuals are more likely to attend their appointments if they like their provider, if they associate well with their provider, if they feel like their provider actually cares about them. Trauma-informed staff are one of the best ways to get doctors on board and to get better access to prenatal care. Not only, do you want a doctor who you feel like likes you or feels like, cares for you, but that also going to those prenatal appointments and that exposure to feeling comfortable may have an outlet for that abused person to speak out, to seek support, to seek shelter services, and engage with domestic violence programs. It also, working with trauma-informed staff can reduce the experience of other children's childhoods, for lack of a better words. It means it can reduce the ACEs on the next generation because bringing awareness and attention to this mom, this birthing person this time, bringing about, oh, some of that is related, kind of connecting the dots where really there might not have been a link before, if that makes sense. Next slide, please. So when we define trauma-informed care, putting it simply, we're meeting people where they're at. We recognize that negative coping skills don't come from a place of joy. We recognize that negative coping skills come from a place of adaptation and survival over growth, meaning they are trying to survive, they're not trying to thrive. And I say they, but it's really, when we talk about especially adverse childhood experiences, many of us have these, many of us, can see ourselves in some of this. It's very painful for many providers to be looking at some of their own experiences and how that might be affecting their patients. It's saying my experience is not your experience and vice versa. It's taking those thoughts and opinions about our own lived experiences and not putting that privilege onto that patient. Next slide, please. So that might sound like, I wonder if, I wonder why, I wonder how. It's actually called Socratic thinking. And it's one of my favoriteest ways to think, because there's no emotion to it, and there shouldn't be emotion to it. It should just why, how, I'm noticing, because the whys frequently get to the root of the problem. Talking about and including conversations with parents that accessing services can also feel traumatizing. And you can't really retain a ton of information when you're in a stress response or when you're in a trauma response. So a lot of things need to be repeated. Please let me know if you're having a hard time and you need a minute to kind of digest. Giving patients that opportunity in the understanding that patients do frequently need an extra few minutes and do need extra support and having repetition. Trauma-informed spaces, like hopefully, like ideally we have in our hospital, seeks to understand where someone is emotionally, mentally, and physically, what they're going through life right now, what are their struggles and what are their goals. So instead of, we like to think of, we know how to do the right way. We know how to do the right way, the right thing, it's down this way, but there's hundreds of ways to do the right thing. There's no one right way, excuse me. And so this would be talking about risk reduction or harm reduction. So talking about, I understand you've been struggling with your returning to use to heroin. I understand it makes you feel much, much better and you feel less sick. Do you want to talk about what we have is in-house is our MAT program. If you're not ready, if you are needing to go home and you're using heroin, do you have Narcan? Do you have someone that will use with you, or do you have someone who will be with you so that they can help you with the Narcan? Not because we, need to use 50 things of, Narcan on everybody, just hand it out like candy, but every time we Narcan someone, it's an opportunity for someone to grow. It's an opportunity for someone to grow above it. It's an opportunity for someone to grow out of what their trauma is. Next slide, please. And so there's 6 principles. We can't get to, we kind of just briefly go around them, but the safety is the first one. Next slide, please. And that's basically making sure that people are feeling safe and engaging in their, sorry, we kind of popped up the safety. Sorry. It's pretty self-explanatory. It's safe. It's making sure patients feel safe, they feel secure, and they feel understood. The next one is transparency and trustworthiness. And that's really questioning your own verbiage and your own thought process. And patients can be really challenging sometimes, especially if their behavior is particularly maladaptive. Asking yourself, is it manipulation, or are they not getting their needs met? Is this person wanting attention for understanding of what she's going through? Versus, this person's just coming in because they are dramatic. Those are things we hear all the time, right? And resistant versus fight, flight, and freeze. I hate the term non-compliant, even though I use it. I'm trying so hard not to use it anymore, but it's such a medicalized term. But a lot of times when you find out why a patient's non-compliant, it's because they don't have access to resources that we all take for granted. They don't have a car, they have to walk, it's snowing outside, they have kids, they have to walk to school. And a lot of people are triggered by going to doctor's offices, and they forget everything they need to talk about and every question they ever had. And they avoid the doctor's offices because it's a very triggering place. Asking yourself, what's the meaning behind this behavior? Next slide, please. Collaborating. And that's collaborating with the patient. Trauma explains the behavior, but it doesn't excuse it. We know that a lot of our communication is nonverbal. I found a slide that was saying that is explaining 65% of communication is nonverbal. So really, it's the way you're approaching things, the way you're sitting. I know when I approach a patient, I tend to always be cold. So I tend to put my arms up. And that tends to not be great for opening dialogue with people. It takes a conscious effort to have that body language to say, I'm open and I'm welcoming to hear what you have to say. Staying curious, not furious. I know that I get irritated. I get annoyed when, patients tell me they're going to come and they don't show. But why aren't they showing? Why are they acting this way? And a lot of the time when you sit down and you talk about it, you realize, oh, well, that wasn't really a reason to get upset or angry. And a huge one that I try to reinforce to our staff is that people's ability to regulate feeds off of those around them. When someone is in just a really, really difficult spot and you can feel the tension in the room is high, everyone raises their tension to be that high. So if you can be that mediator that is acknowledging and aware of that dysregulation, it's a huge impact on the overall team group. Next slide. I think I have 2 more maybe. So a lot of traumatized persons will struggle with control and power, and that makes sense when you're thinking about trauma that we go through. It reflects a time in their life that they were unable to feel, to have either independence or control. Asking open-ended questions are great. I love to kind of script the staff. Talking about you statements can feel very attacked. You don't do this. You didn't bring your sugar log. You didn't collect your urine. Instead, taking that off the table, saying you don't do, saying, I'd like to hear your thoughts on what I'm hearing is, that sounds difficult. Let's talk about this. Employing the yes and technique. And only because I love to put that into, it's when someone says but in a conversation, it just erases the first part of what everyone says. So Libby, you were great, but I'm like, well, now I'm not great. Now you got to tell me all the bad stuff now, because that's all I'm going to focus on. It doesn't feel, great to hear that, but yes, and sounds a lot different because it's giving the credit where it's due and provides an opportunity for either constructive criticism or an opportunity for learning, which can be growth. Next slide, please. Because we all have baggage. We all face adversity and we all face challenges, and we have internal in our brains expressions and feelings and opinions of those challenges. Your unique opinions, experience profoundly affect a patient's treatment outcome. That's why I love to, I know that I'm a giant nerd for the clip art, but if you never heal from what hurt you, you bleed on people who did not cut you. And that's what a lot of traumatized individuals are doing. They're leaking their trauma and their anger and their feelings on people who really don't necessarily, are absolutely not the person to be at, but sometimes the only safe person that it can be at, if that makes sense. Doesn't make it okay, but it does explain it. Next slide, please. So empowering is the next tenet, and it's giving the voice and a choice. Providing this care allows them to express feelings that are common in light of what has happened to them. Basically, what happened to you wasn't normal, but what you're feeling about it is. It can be very isolating to have an experience and feelings and emotions and not understand them because other people simply don't have that experience. Allowing the feelings to be acknowledged for a lot of people can be eye-opening. Asking permission rather than seeking, asking permission rather than walking over and telling you, I'd like to check, I'm going to check your cervix now. Asking our providers, before they put on the gloves, before they want to do the cervical exam, sitting down and asking them, I'd like to do a cervical exam if that's okay with you, and then getting the glove. Because I know when patients walk in and a doctor walks in with a glove on, the implication is that you're going to say yes. The implication is that you don't have control over the situation. And you're already starting off on that foot where she doesn't feel like they don't feel like they have that choice. Normalizing the conversation and talking about, it's really uncomfortable to talk about substance use, especially when you're pregnant, because a lot of people have some really strong feelings and some big opinions and attitudes. I just want to hear from you and talk about how you're doing otherwise. There's not a one right path to recovery, and just showing them that there's a whole forest that they can take. Involving the patients in the whys, why we are doing X, Y, and Z. Next slide, please. So scripting, these would be avoiding phrases like, these are very, like all of these ones I've actually heard somewhere in the labor sphere. Make a fist like you're getting in a fight. Frequently they've been subject to violence, which is, potentially very triggering. Lift up and sit your bum on your hands. So when you sit your hands on your bum, it changes the position of the cervix sometimes and makes for an easier exam, which is great, but you're taking away autonomy by pinning the patient's hands down. And that can be also very triggering. I think good girl speaks for itself, but we still hear it. It makes me like cringe every time. Open your XYZ for me. I've heard like open your legs or pull out. I'm like, not for you. Nope, we're having it because we're doing it for the baby and because mom's making, that movement. It removes autonomy. These are some of my insteads. Next slide, please. And then we talk a bit about secondary trauma and how it relates to our own windows of tolerance and how we can be touched. Everyone bleeds on us a little bit. Everyone touches a little bit of trauma, and it's impossible to not come away with a little bit of secondary trauma. And next slide, please. And that's the last slide. Yeah. We talk about ways to mitigate secondary trauma, and I know it sounds like very floral and soft, like, oh, decompress with your peers, do yoga. Sometimes yelling and crying and swearing with your friends about something is what you need to do to get rid of that. That anger is energy in your body. That anger is somewhere. Sometimes it needs to come out, and decompressing with your peers is probably one of the best ways to mitigate secondary trauma, in my opinion. In addition to practicing mindfulness and being aware of your body and its sensations. Everyone, the big point of this slide is that no one's immune to trauma. We all absorb it and process it and manage it the way our nervous systems will do that. Unresolved emotions from these experiences result in negative coping techniques, which is why there's so many health cares who have substance use disorders. The end. Thank you so much, you guys.
Thank you. That was fantastic. I'm feverishly taking lots of notes. We're also in the midst of doing lots of training for trauma-informed care, and this was really, really helpful, Libby. Thank you so much. And thank you, Sarah. Yeah, and thank you, Sarah, for a really great conversation on really what it took to get the work done and to move the work forward. I just want to say great job to all of you. I know we're at the hour, but I'm just looking in the chat to see if there were any questions. Lots of accolades and celebrations.
Hi, this is Callie from Mercy. Could I ask a question? So first of all, Sarah and Libby, you guys did amazing. I loved your presentation and everything that you've done. I was like snip, 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 like saving things in an email so I can read them again. And I know, Libby, you put a ton of work to creating this PowerPoint in this class. And I was wondering if it's something you'd be willing to share with us so that we could share it with our staff possibly.
Yeah, I believe that's definitely, we can do that. We shared it before, I think, previously. I think Sarah did before previously. Yes. Okay. And I can share with you the complete slide. It has references on the last page. It also has a little bit more detail and it goes into a little bit more detail. You know, it's about maybe a 2.5 hour class in total.
Okay. Awesome. That would be amazing. Thank you so much.
I wanted to speak really quickly before I have to head to the PFAC. Hey everyone, Kristen, Audra. It's been a while. I'm actually due to give birth. I'm only 35 weeks, so we're like heading in there. But I really appreciated the pushback on softening the anti-racist statement. That felt really validating to hear. And it's really good to know that we have allies who are willing to like have those uncomfortable conversations. And a part of my work with Pinquin comes from a negative interaction I had with a lactation consultant who just moved forward with the glove and like didn't really ask permission in a way that really took me aback. But, you know, thanks to Mimi, I was able to take that experience and be in this space and give feedback as a mom and a patient and a person who's looking to push forward equity. So it was really good to hear that we're moving forward as a community.
Awesome. Thank you. I have to say, I really appreciate the validation because it's been quite a process. And good luck, Shaniqua.
Yeah. Thanks, everyone. Have a great rest of your week.
Thanks,
Thank
everybody.
you.
Hope to see you at the summit on June 26th, and then for our last equity webinar on July 16th. Take care, everybody. Thank you, Sarah. Thank you, Libby.